There are a lot of reproductive endocrine centers in the United States, but I wanted to talk about a few of the things that I think makes us unique. When people talk about in vitro fertilization, they say, do you do a day 3 transfer or do you do a day 5 transfer? Well, there's always, doctors always like playing with new toys, so that it's just the way we are. So when all of a sudden some theory comes up that, well, if you could let an embryo go to day 5, then this would, number one, select out the survival of the fittest, that the embryos that would be the hardiest would make it. And then it made some logical sense that if normally the embryos are in the fallopian tube on day 3, and they don't make it until the uterus till day 5 or 6, isn't the chemical environment that you're putting a day 3 embryo in the wrong kind of environment? That wouldn't it make sense that if you put it in on day 5, that it would work better? And then we also know that progesterone quiets the uterus. So sometimes if you put an embryo in on day 3, the uterus is still a little bit contractile, and you might expel the embryos out of the uterus. But if you wait till day 5, it's more quiet, and that now you get better pregnancy rate. So it was thought. But it turned out in reality that it really didn't show a better pregnancy rate, because as it turns out that the more that an embryo is out of the body, the more harm can come to it, and the more things can occur. Now, but it leads to sometimes false statistics. So, for example, let's say that a doctor wants to keep his statistics up because people look at that. It's recorded. It's one of the few areas of medicine where you can pick your doctor depending on how good their center is. So to be a good center, you should have a good embryology lab and good doctors, good experience. But also, if you want to be the best, you have to know how to play your audience. So, for example, a good maneuver would be that if the person has bad-looking embryos on day 3, and you're afraid that they won't get pregnant, tell them you want to wait till day 5. They won't make it to day 5, and so you have no embryos to transfer, so now you don't get a demerit for a failure to get pregnant with a transfer, because there was no transfer. But the woman went through retrieval, stimulation, all that, paid for the cycle, and doesn't get a transfer out of it. The doctor gets no demerit, but that patient is the one that paid all that money and didn't get anything from it. That should be counted in the statistic. But that's a little maneuver that people can do. So there's always a saying that figures can lie and liars can figure. But what I don't like about it is, and I've written articles about this called the pregnancy rate per pregnancy harvest to show what that means, that you want to be able to get the best bang for your buck. So if you're using a high-dose stimulation protocol, you want to have the most embryos. Number one, if the drugs have an adverse effect on conception, like the woman from Israel, and if you wound up with just very few embryos at the end because you waited for them to grow to day 5 and you lost a lot, then you won't have the advantage then of being able to put frozen embryos back because they were all gone. And if there was something about your insurance or something about your health, or something happens to your ovaries, that if you wanted a baby a few years from now, if you didn't have that many frozen embryos put away, then you'd have to do IVF again, and that's what happens when you do blasts. You lose a lot of embryos going from day 3 to 5. But some people say, well, what's the difference? If an embryo doesn't make it from day 3 to day 5, they're not going to make it in my body, and that is far from the truth. And I can tell you that although there is correlation between the quality of the embryos on day 3 and their ability to implant, any embryo, that as long as it gets about 4 cells, has the chance of implanting. So I'll tell you about another study, because this brings this up at this point. There are some people around that claim, and one of the biggest and best IVF centers in the world made a statement that if a woman has a day 3 FSH ever in her life of 15 or higher, that they can't get pregnant because their eggs are no good. They're like an old woman. I mean an old reproductive woman. At my age, I certainly wouldn't want to think that a 47-year-old woman is old. But nevertheless, from a reproductive standpoint, very, very few women ever will get pregnant 47, 48, 49. There's some rare families that do, but it's because the eggs are defective and there's a high rate of chromosome errors. And that's why. And they think that women that are younger, that have the same amount of eggs left as a woman that's 48, must have the same type of problem, but it's different. That in a younger woman, that when they have had a high FSH, the majority of them have not had a rapid loss of eggs and the way it does in the normal process of aging, where the best eggs are lost first. What's happened is there's been some destructive process that has wiped out a lot of that population, but the eggs that are remaining have the same proportion of good eggs and bad eggs as their age peers. But it's the way that the doctors are treating the people by trying to create multiple eggs that it is actually shutting down a receptor, what we call an FSH-dependent protein that attaches to the embryo that is important for the embryo to implant. And if you circumvent that, you can get good pregnancy rates.